Hello, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor, JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, please send us your questions or comments on Twitter, mention us at JAMA Network Open, or put them in the comment box under the video on Facebook or YouTube. So today, we have got the effect of pregnenolone versus placebo on self-reported chronic low back pain among U.S. military veterans, a randomized clinical trial. And we have first and senior authors Jennifer Naylor and Dr. Chris Marks with us. Welcome.
Thank you. Hello, thanks. Great to be here. Thank you for having me.
Really glad you could join us. It's an interesting paper. So tell us a little bit about yourselves and about neurosteroids for back pain.
Sure. I'm Chris Marks. I'm a psychiatrist here at the Durham VA and at Duke School of Medicine. Here at the VA, I treat veterans who've served in the U.S. military since 9/11, and I co-direct the research core of our center grant here at the VA. At Duke School of Medicine, I'm a professor and vice chair for faculty. And we've been focusing on a class of molecules called neurosteroids, which are endogenous molecules. They're naturally occurring. And we're very interested in them as biomarker candidates and as therapeutic interventions as well.
Yeah. Great. And I'm Jennifer Naylor. I'm a clinical psychologist within the Durham VA healthcare system, where I work clinically with veterans who have chronic pain conditions. I'm also a co-director of the Mid-Atlantic MIREX Clinical Core and an associate professor in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center.
Okay, so neurosteroids for low back pain. Tell us about that.
Sure. Well, some of our early investigations in the area of neurosteroids have shown that these molecules are decreased in certain conditions, including pain disorders. And so the overarching hypothesis has been that perhaps ameliorating these deficits is therapeutic. And some neurosteroids, such as allopregnanolone, which is a downstream metabolite of pregnenolone, have analgesic actions in rodent models as well. So we were really interested in trying to translate that into a clinical trial, which Dr. Naylor has been leading.
Yeah. And we were focused on pain because it is so incredibly prevalent and common in our veterans. And it certainly can result in pretty substantial functional impairment and a real reduction in quality of life. In addition, chronic pain conditions can really be challenging to treat in this particular cohort, as veterans often are reporting complex comorbidities, like pretty significant mental health conditions and also physical and medical conditions. Long-term opioid therapy was once a first-line treatment for chronic low back pain, and we now know that opioid use may not be the most effective treatment for chronic pain conditions, as it's associated with significant addiction and other side effects. The over-reliance on prescription opioid medication has likely played a substantial role in the recent surge of opioid-related addiction and overdose deaths. Thus, the developments of non-opioid pharmacological interventions that are able to maximize analgesia and maximize function while minimizing risk and outcomes has become a rational priority. And as Dr. Marks mentioned, neurosteroids hold promise for a safe and effective intervention for the treatment of chronic pain conditions and commonly co-occurring disorders.
Okay, great. Well, we've got Richard who's joined us. Welcome. You've got perfect timing because we're going to talk about this RCT. So you had 94 veterans, mostly kind of, I'd say, relatively young men who you're able to randomize into this trial. And what did you do? What did you find?
Yeah. So as you mentioned, we conducted a randomized double-blind placebo-controlled trial to determine whether pregnenolone reduced chronic low back pain in Iraq, Afghanistan era veterans. Veterans with chronic low back pain were randomized to receive either placebo for a duration of 4 weeks. And we used a fixed escalating dose of pregnenolone or matching placebo. So following a 1-week placebo lead-in period, participants received a 1 week of 100 milligrams in divided doses. And then the second week, they received 300 milligrams in divided doses. And then they received 2 weeks of 500 milligrams, both in divided doses as well. Our primary outcome was the change in a numerical rating score of pain intensity. So we utilized, the participants actually utilized a daily pain diary. So they recorded their average pain over the course of the day, that over the week. In addition, we collected what we were calling a pain recall score. So individuals who came into their visit, we asked them how, just to reflect back on the last week and give us their average pain score. And the secondary outcomes were pain. So we used the brief pain inventory to look at functional impact and how much pain was interfering. What we found, okay. Sorry.
Oh no, I was just found a little curious. I'm used to seeing tapers from steroids, not increasing escalating doses. Can you explain why you did that?
Really to make sure that the neurosteroids were well tolerated, which as we've seen in a number of randomized controlled trials now in schizophrenia, traumatic brain injury, other disorders. So far, pregnenolone has been extremely well tolerated, and so of note, very different from the glucocorticoids, for example, where you have a course and then you have to taper, otherwise you get rebound effects. We're really not seeing that, actually, even with abrupt pregnenolone cessation. Some of our studies have had cessation, some have tapered as a precaution, and people have tolerated both very well.
Interesting. All right, great. Sorry to interrupt it. So tell us about your findings.
Yeah. So we were seeing some significant reductions in self-reported low back pain, and so we're optimistic that this could lead to additional studies, perhaps looking at other kinds of pain, perhaps longer duration of treatment. We're not sure if improvement could continue that symptoms could continue to improve. And also we'd want to look at adverse event profiles as well. So far, the adverse event profiles have been very favorable, thankfully, or unfortunately.
Yep. That's great, because as you mentioned, even outside of the veteran population, we know there's big opioid epidemic, not just the safety lack, but really lack of efficacy for opioids for chronic pain, and just I'm certainly interested in having more tools in the toolbox.
Definitely, yeah.
Absolutely, and hopefully this could even be a multi-pronged approach if the other studies turn out to be potentially helpful in some way for co-occurring PTSD. We do have some initial studies in which people with PTSD have markedly reduced allopregnanolone levels, and we're trying to replicate that in independent cohorts to see if that finding persists.
And was there any sense of, I know you had mentioned that in the future hoping to look at duration longer than 4 weeks, but was there any sense in terms of these patients of sort of immediate impact versus a little bit delayed? Did you see anything like that? Did it make a difference in terms of the dose?
Oh, that's a really good question. There are a lot of dosing questions that still remain. We're still needing to do some work in that area. But perhaps a common comment after completing a study has been, can we continue this? And was I randomized to pregnenolone? And in some cases, people had been in unblinded studies. And so a lot of interest afterwards, I guess, which is potentially promising. Anecdotal, so not to overstate, of course. Actually, our dropout rates were generally higher in the placebo group than in the pregnenolone groups in a number of our studies, the TBI study, for example, and in the schizophrenia study.
Interesting.
And we did see progressive changes across the 4 weeks, where we, when in comparing placebo to pregnenolone at that final 6-week period, we saw a 12% decrease relative to placebo at visit 6. And the pain diary group, and in the pain recall group, that was even a little bit greater at about 15%. And then we looked at treatment responders, and we found that those randomized to pregnenolone were 2.5 to 2.6 times more likely to report 20% reduction or greater than those randomized to placebo. And then we also looked at the magnitude within each group, magnitude of change, and we saw that those randomized to pregnenolone were reporting a 20% reduction, where those randomized to placebo only reported a 6% reduction, which was one of the most surprising findings in our study due to the typical placebo response. We also looked at pain interference, And we did find that for 2 of the domains that we assessed for, activity and work did significantly improve over the trial in this group. And so, as Dr. Marks had mentioned, it's unclear if we extended the duration a little bit longer, whether or not we might have seen more improvement in interference as well as in the pain intensity ratings. And as she also mentioned, we don't know the optimal dose quite yet. But we do know that it was very well tolerated, which is really exciting.
Yeah, the dose is a little too low, maybe. Very unanticipated.
I guess just taking a step back, how did you define chronic back pain? And I asked, particularly in this population, for example, I would imagine that mechanism of injury might make a difference. So, a combat injury, for example, would be different than osteoarthritis, potentially.
Yeah. Well, we did have some pretty strict screening criteria, and we were really trying to isolate more musculoskeletal pain in nature. Yeah. So no radiculopathies, no nerve involvement. So it was pretty strict criteria and to get in. We tried to make it as a homogeneous population as possible.
Yeah, that was actually something I found really interesting because I'm not going to pretend I know all the literature on low back pain treatment, but from what I know, the best data for steroids in kind of routine back pain are for radicular pain, and it's kind of interesting that there's such good outcomes here in very specifically non-radicular pain.
Yes, absolutely.
So
I agree.
I was certainly promising.
Yeah.
All right, great. Well, thank you so much for joining us. This is really an interesting paper. Again, low back pain is common. Chronic pain is I think we're all frustrated by our lack of safe and effective tools.
Yes.
Certainly looking forward to seeing more work from this. So thank you so much for joining us.
Thank you so much for having us.
Great. Take care. All right. Well, I think you have the first paper today.
I
What
do.
do we have?
Yes. So this is an editorial, USPSTF's Hepatitis C screening recommendation, a necessary step to tackling an evolving epidemic. So the USPSTF just released a new recommendation, I think it was last week, that looks at hepatitis C screening. So the prior recommendation was from 2013, I believe, and that one had a recommended screening for people that were perceived to be at high risk, but also for individuals born between 1945 to 1965. The thought behind that is that those patients may have received blood before blood was being screened, which started, I think, in 1992 in the U.S., and also may have had other risk factors that would sort of make them a higher risk group. However, since that time, the epidemiology that we're seeing in terms of new hepatitis C infections has changed. And so this new recommendation actually recommends, sorry, I can't think of a better word than that, screening, doing a one-time screen of everybody between the ages of 18 and 79, I believe. So this editorial is sort of addressing that and a couple of other things related to that. And I just have to give a shout out to one of the authors, Josh Barokas. He was actually a colleague of mine in fellowship and a great researcher in hepatitis C. So the authors in this editorial talk about the fact that this new recommendation sort of reflects the fact that we're seeing, new infections in different population sort of now in the last decade or so, particularly more infections related to IV drug use. And a few things that I thought were sort of interesting were, one, just sort of the idea that universal screening is acknowledging this new sort where a lot of the new infections are coming from. But then they also talk about the fact that that there are still a few things that we need to think about as providers, as clinicians. One, this is a one-time screen recommendation. So, if you're talking about young adults, that's going to potentially miss subsequent incident infections. And so we really need to, as practitioners, consider risk factors in these individual patients. And the other point, which I thought was very interesting, was that ideally, hepatitis C screening recommendations could be targeted towards those who are really at high risk. But as a society, we've stigmatized a lot of the behaviors that are associated with higher risk patients, I guess. And you know, as practitioners, we are not that great at necessarily eliciting those high risk behaviors. And so that's kind of one of the thoughts behind screening everybody, is that hopefully you'll catch that population within that. And, you know, they kind of advocate for or encourage thinking about supportive actions at the state and federal level to try to reduce some of that stigmatization, but then also really thinking of sort of one step beyond screening and how are we going to help those patients, how are we going to help kind of reduce some of the risk factors. And so things like facilitating expansion of federal funding for syringe service programs and supporting safe consumption sites are really important. So, you know, a great sort of a step forward in terms of the SNE recommendation, but certainly things that we need to all kind of continue to work on to help reduce the incident rates of Hep C.
Yeah, absolutely. I found this was a really interesting editorial that tied so much together. Before I get into that, going to welcome Durali Simsek, Brad Day, and MSc Mechanical who've joined us. But other stuff, I think some of the other key points, you know, we've now, since around 2013, we now have curative agents.
Yes,
we have this curative direct antivirals, so there's much more that we could do than back in the day. They point out that 1 in 5 diagnoses between 2014 and 2016 were made in people with advanced liver disease.
Yeah.
So, you know, we're finding people late. We're basically the only option is maybe a transplant.
Yeah.
And, you know, just as you were saying, you know, most of the new infections now are driven by injection drug use. And the stigmatization just makes it both many reasons why patients either don't have access to care, or when they do see providers where either are reluctant to for, you know, stigmatizing reasons, or we're bad at eliciting that, having those tough conversations. And again, I really like how they kind of wrap it around and just say, you know, this is, as you got it, this isn't just a one and done. We're doing it. This is part of, this is necessary but not sufficient, because I think the words they used.
Yeah, exactly.
And,
I think that might have been the last line, actually. It was great.
But needle exchanges, better medications for opioid use disorder, all that kind of stuff. So really nice stuff. And also, it's always nice to see something that, like, I don't know, not just resonates, but it's like, oh, this is a nice, mature, well-developed, like, this is good. This isn't everything.
Absolutely.
Let's treat the whole patient, the whole problem.
Absolutely.
So it's really nice.
Yeah,
so
I agree.
Nice. Yeah. I didn't really think about it until probably a couple of years ago, where I saw a patient who's roughly my age who had end-stage Hep C from blood transfusions for jaundice. And it was my age. I had the same thing. You know, this is well before we, you know, I don't even think Hep C was even called non-AB hepatitis at that point. We didn't know about it. And it's one of those, like, wait a minute, like, it's scary.
Yeah, definitely.
This is really scary stuff, and it's just such a different era.
It is, definitely. As you mentioned, we now have such effective treatments.
Right.
So, you know, working on other ways to try to engage people in care and destigmatize, I think it's important.
Absolutely. So moving on, we've got Louis Fincham's joined us, and what do we have next?
So this is the analysis of patient-physician concordance and the understanding of chemotherapy treatment plans among patients with cancer. The objective of this study was try to look at the concordance and understanding between patients with cancer and their oncologists in terms of their chemotherapy plan. It was a really cool study. It was cross-sectional. They used a questionnaire. This was in a hospital based in Saudi Arabia. They enrolled 151 adult patients and found that only 20 patients, so about 13%, had full concordance with their physician. So full kind of, both the physician and the patient had a similar understanding about what their chemotherapy plan was. And really interesting, the authors also dived into what were sort of factors that led to disconcordance. The most common aspect of disconcordance was actually duration of therapy, which is sort of interesting. It kind of makes sense, but very interesting. And that actually full concordance was more likely among patients that had college or advanced degrees, and also patients that came from a family that had a history of cancer as well. Also, I think kind of makes sense.
Yeah, which is intuitive, but kind of sad.
It is. I agree. Yeah. So really interesting. And, you know, I think they end by saying we really need to work harder on improving communication, particularly for something like this. It's going to be not necessarily long term, but, you know, there's multiple visits, and it's really important to get on the same page early on for all parties involved.
Yeah, and it was just to run through the numbers is really interesting. So 68% were discordant on there, saying a duration where it's like this is how many weeks you're going to need this therapy. 45% on the frequency, so how often you're going to come and get your treatments. 31% on follow up, 32% on goals, like you said, which is again that's to me pretty scary as well. 22% on the toxic effects of the chemotherapy, and this one was probably the most startling is that 18% disagreed on their type of cancer.
That was really, I couldn't believe that actually. It's pretty high.
I mean, this is, some of this stuff gets really technical and it's emotional. And I've certainly had conversations with patients where I'm not surprised, where I expect them to not retain most of the information we talk about because it's a big life-changing discussion or whatever. But when patients are in therapy, I don't know. I think, and I'm sure there's certainly some patient limits to how much information you get, but I think everything we know or everything we've seen is we as a profession can do a much better job communicating.
Yes, definitely. And I feel like the next step is trying to figure out how we can do that.
Right.
Because it may not just be, as you said, it may not just be a matter of having a long conversation.
Right. Yep.
There may be other things that need to happen.
Yep, absolutely. So changing gears to EHRs, one of the things that potentially keeps us away from communicating with our patients. I thought it was a really fun interesting study. So these were this from Kaiser Permanente, Northern California. They looked at some of their EHR audit data from 2018, 2019 to look at how healthcare workers were using the search function in their EHR, which is fascinating. So there were 35,000 users. It was a variety of different types of practitioners: docs, pharmacists, nurses. Made up the majority of them, but then there were a bunch more. They overall did, I think there were 10 million patients involved. There were 4 million searches they found with 8 million result views. Like they clicked on or hover to discover over the results. And it also did some analysis of things like search episodes where you found like somebody does a couple of different searches together where they linked search terms. Basically, they found about half the searches were done by docs, which isn't surprising. 16% by pharmacists, 6% by nurses. The overall most common terms were statin, colonoscopy, and PFT for pulmonary function test. But like a lot of things, those weren't that common. They were like 1.7% each.
I know.
And then when you divided it up by type of practitioner, it changed a lot. So the docs mostly searched for the most common things were things like colonoscopy, PFT, and then diseases like sleep apnea or asthma. The pharmacists, not surprisingly, looked mostly for drugs. So statin, metformin, lisinopril were at the top of their list. And one of the kind of heartwarming things was that both nurses and social workers, most common search terms were palliative and palliative care. But then also nurses also look for statin and then Foley, of course. The mental health providers look for social workers and social services a lot. APPs, this is really interesting. Most common search term was OpNote. And then MoCA, which is the functional measure, and also colonoscopy, which my guess is that has more to do with which types of specialists have more APPs in practice.
I agree.
Would be my guess. But yeah, I found it interesting. From my casual observations, I tend to use our search a lot more than a lot of my colleagues. I would say the big things I look for are goals of care, echo results, and also my name, because if something's kind of familiar, to see if it's a patient I've seen before. Which I look for a lot and and can be very helpful. And it's nice.
One of the things I was interested here was that the Kaiser system is very large, but this one was focused on Northern California. So I was wondering if there may be geographic differences, and certainly part of that probably is patient population too, and thinking about certain risk factors, et cetera, in terms of what you end up searching for, or maybe it's things that are difficult to find.
And a lot of it is I mean, we've talked about this before, the signal noise ratio in the EHR can be rough, and I feel like sometimes part of the reason why I use a search is because sometimes there's so many things to go through, and just trying to find that OpNote, or that did they have a colonoscopy before, did they have a stress test, or what's this relevant piece I'm looking for, is really helpful. And I also I like data visualizations, and this network graph is really cool.
It was so cool.
And it's nice how things are linked, and again, a lot of this is going to be not just by provider type but by specialty as well, I would imagine. And we've got some close-ups, but things like people who look for colonoscopy also look for things like EGD and H. pylori, which isn't surprising. Asthma and GERD and echo and COPD and spirometry and PFT and ADVAIR are kind of all together. And then in this second close-up, This has to be either the mental health or the pharmacist one. No, this got to be mental health because it's Effexor, Prozac, Seroquel, Depakote, Topamax, nortriptyline, duloxetine, gabapentin. Gabapentin was up there on a lot of the lists too.
Yeah.
And then on this third close-up we have, this I'm going to guess is the pharmacy one because aspirin, statin, atorvastatin, lisinopril, furosemide is all just kind of common medication names.
Yeah.
So it's really interesting stuff. It's also kind of nice because this is descriptive and interesting and also kind of resonates and makes sense.
Definitely.
No big surprises here. Now I'm curious what my search results really are.
Yeah, check it out.
Right. All right, so moving on to our quick hits. So first up, going to welcome Ender and Vedat. Welcome. We're on our quick hits. First up, we've got yet another paper on combining artificial intelligence and radiologist assessments for mammograms. They had 310,000 screening mammograms, which is a lot. Found that none of the AI algorithms outperformed the radiologist benchmarks by themselves. There was some incremental improvements in specificity when they added the AI to the radiologist assessment. And this is one of those things where, I will bet my nickel there's a future where AI is doing a bulk of the work in radiology reads, but it's still seems pretty far way off. The invited commentary that comes with it, I'm stealing some lines from the conclusion that AI is not there yet. Today, even with an incredible amount of resources, arguably the best AI teams in the world could not meet or beat the radiologists.
Yeah. So there are a couple of things there. I guess one, again, being married to a radiologist, I wonder about, what I've learned from my very basic understanding is mammograms, there's actually quite a lot of nuance related to it. And so certainly I can see why it might be difficult to, design AI or to teach AI how to be able to really read it proficiently. The other thing I wonder about, we often talk about, we as society often talk about AI replacing humans or replacing whatever jobs, but there may also be a place potentially in the future for acting more as an adjunct, assistive rather than as a replacement. And I don't think we talk enough about that particularly. Right. And in this, scenario, I could see that somehow helping radiologists in the future.
Yep, absolutely. I mean, I think I've anchored on this because the first time I read something about this probably a decade ago, it was on mammograms and they highlighted areas for the radiologist to look. And that to me makes the most sense is not, like you said, the adjunct, not replacing radiologists, but augmenting or adjunctive. Is to me that's the most plausible, especially just with the level of computers that we have and where things are. And, as helpful as, my smartphone is, sometimes making suggestions, sometimes it's just terribly wrong.
Yes.
Right. And AI is only as good as we can make them.
Yes, exactly.
All right, next up, this is a little bit of a sad paper. Again, not surprising, but the association of formulary exclusions and restrictions for opioid alternatives with opioid prescribing among Medicare beneficiaries. Not surprisingly, basically, when they looked at how alternatives to opioids were covered by county, the rate of opioid prescribing increased by 2 to almost 4% for every additional opioid alternative not covered, which is not at all surprising. No. There's a little nuance there. There's also a nice graph figure 3 here, which kind of shows what is and what is not have formulary restrictions. But it's just not surprisingly when there's more friction in doing things besides opioids, the more barriers there are to non-opioids, the more likely you are to prescribe opioids.
Yeah, that's really interesting. I'm also very interested. So is this figure meant to show topical analgesics as being more difficult to obtain? That's really interesting to me because I feel like actually on the inpatient side we use it not frequently but with relative frequency. And people do get a benefit from it, at least anecdotally. So
yeah, I mean, my guess is that it's just kind of the inertia from the topical analgesics tend to be newer, so tend to have been generic less recently or less well studied and more expensive more recently, and it just takes time. Yeah, I mean, I'll say I've said this before. I use lidocaine patches a ton in my practice. There's not great evidence that they work, but there is good evidence they're safe. When they're covered, they're cheap. When they're over the counter, they're cheap.
Yeah.
Instead of it helps. If nothing else, I'm doing something. Yeah. I'm caring for the patient.
Yeah. Exactly.
Welcome, Kenda's joined us as well. We've got one more paper. This is an interesting one. So, comparison of rates of central line associated bloodstream infections in patients with 1 versus 2 central venous catheters. So, not surprisingly, patients with more than 1 central line are more likely to get eclampsia. And some of it makes sense just because if you have 2 lines, you probably got twice as much exposure. But also the reasons why people need central lines. If nothing else, for one, it's a marker of how sick you are. And for two, the reasons they used them, 44% of them were for dialysis and 14% of them were for nutrition. Some of them, I don't know the number, were for chemo as well. So basically, the bottom line number, they looked at 50,000 patients at 4 hospitals, about a 1% central line infection rate, which seems pretty good, is about right. But having 2 CVCs for longer than 2/3 of a patient's CVC use duration, adjusting for central line days and comorbidities, still had an adjusted risk ratio of 1.6. So it's pretty decent.
Yeah, I think it makes sense, as you said. I think if I recall, they also note that I don't think it was quite a limitation. I think they may have adjusted for this, but thinking about the type of CVC, right? Because certainly some may be more at risk than others. If you're, or even the way that it's being cared for, if you're constantly accessing it or whatnot, it
like
makes
dialysis.
Right, like dialysis, exactly.
Yeah, and just I mean, sick people need central lines, and sicker people need more central lines. So you're gonna have more problems, and and I think our understanding, or my understanding of our understanding of a lot of sterility, it's still about just how much exposure and just time. And the more time you're doing something, the more time you spend touching a line or doing something, the more likely it is to get infected. So just try as much opportunity, if nothing else.
Yeah, definitely.
All right. Well, that is all we have for today. Join us again next week, 3 p.m. Central Time, if the city doesn't go on lockdown, which as far as I know, there's no sign it's going to. Of course, get the audio portion of the author interviews on the podcast. Follow us on all the usual social media channels, and take care.
Thanks, guys. Bye.
Wash your hands. Don't touch your face.